Hello everyone. Welcome everyone to the Master Nursing classes. So in the last previous class we have discussed the most of the important questions, that is how to calculate the body fluid by using the Holiday-Segar formula, and we have discussed some important questions on the pharmacology, that is from the mannitol, from the sumatriptyline, and some diuretics like furosemide. Okay, so and we have also discussed the important question on the psychiatric terminologies, that is very much important and they repeatedly asking in the previous exams. Okay, so the questions which all are asking, so that is I am trying to bring in front of you all. Okay, so very good evening beta, good evening everyone who is live to the class. Welcome everyone once again to the this wildfire session number 4. In the last session we have discussed the most of the questions, important questions and important concept also, and in this second session also I have discussed the most important questions, that is from the concept based questions and scenario based questions, and everyday wildfire series session which is having the one liner questions, which is having the scenario based questions, practical based questions, everything we will discuss. Okay, bacho, if everything is clear and wise board, everything is clear, we will move on to the class. Yes, do thumbs up. Very good evening, very good evening to everyone. Yes, can anyone please do thumbs up here? So is my voice and video everything is clear? Yes, so we'll start the today's class. Welcome everyone once again to the wildfire series. If anyone is new to the master nursing classes family, do subscribe to the channel bacho. Yes, and hit the bell button given near to the subscribe button. So after hitting the bell button only, you people will get notified for each and everything I am posting over my YouTube. So that is the important posters, important pamphlets, important questions. Okay, so everything what I am posting in the YouTube, so that will comes to you if you clicking over the bell button. Okay, so do subscribe to the channel and click over the bell button, so you will be get notified for each and everything that is shared by the master nursing classes. Okay, so bacho, yes, without wasting time we'll start the today's class, and here is the beautiful motivational quote for you all. Okay, so success is a sum of the small efforts, okay, repeatedly you people are doing day in and day out. Okay, so this is the actual way. Okay, so I am watching some of the peoples, they are consistently watching the classes. Okay, so this is the small efforts you people are doing to gain the knowledge. Okay, so I am hats up to your consistency, what you are, okay, connected with the master nursing classes. Yes, so these small efforts what you people are doing to learn something, what you people are doing to trying to understand the concepts, so this is brings you people to towards the success. Okay, so this is the beautiful motivational quote for the day. Okay, here is the first question in front of you all, so do read the question properly, so then try to give the best answer in the comment box. Okay, yes, the question is very simple. A patient undergoing a seizure in section, okay, patient is undergoing a seizure in section, is typically positioned in which manner? Okay, so in which manner we have to position a patient who is undergoing a seizure in section? Okay, so this is asked in the last NORCET, very important question. Yes, so option A is the supine with the left lateral, option B is the supine, option C is the Trendelenburg position, then option D is the prone position. So which position is best while during the seizure in section? Yes, do comment in the comment box. Yes, almost all of you have given the correct answer. That is a supine with left lateral tilt is the correct answer, bacho. We can't give the supine alone. Why? Because understand the concept. This is the labor table. Okay, so on the labor table, the woman is lying here. Consider she is a woman. Okay, and this is the large abdomen of the woman, and here is the uterus of the woman. Beneath the uterus, as all of you know that there is major venous supply, which is carrying the venous blood return from the foot towards the heart. That is the inferior vena cava. Okay, so this is what we call the inferior vena cava. Okay, so if you are giving the flat supine position, if you are giving the small flat supine position, so this uterus creates the compression over this inferior vena cava. So this inferior vena cava compromised here means the blood returns will not go towards the heart. The blood return which will not go towards the heart means, yes, the heart will pump less blood. The heart is pumping less blood means decrease in the blood pressure is there. So this is what we call as the hypotension. What we call this one as in the hypotension. Okay, hypotension occurring because of the supine position. So we call this one as in the supine hypotension syndrome. Okay, very importantly, all you people have to understand. Yes, the supine hypotension syndrome risk is there because of the compression over the inferior vena cava. Okay, if you are giving the supine flat position, okay, that is what we have to give the supine position with slightly tilt towards the left side by keeping the pillow under the right hip. Okay, you have to keep the pillow under the right hip, so patient will be tilted towards the left lateral side. Okay, is that clear? So this is the reason and important thing all you people have to understand for the positioning during the LSCS. Okay, here is the next beautiful question. I am waiting for your answer in the comment box. Do comment fadafat. Which of the following is the correct method for administering the insulin for optimal absorption? Okay, for the better and best absorption, what is the correct method we have to administer the insulin here? Option A is telling that inject the insulin into the muscle tissue. Okay, option A is telling that inject the insulin into the muscle tissue. Bacho, so which route we have to administer the insulin? Which route we have to administer the insulin? Yes, do fatafat comment here. Which route we have to administer the insulin most of the time for the diabetes management? Yes, that is the subcutaneous. What are the thing we need to administer mostly during using the subcutaneous? That may ask in the exams. Yes, administration of the insulin is the subcutaneous route, always recommended. Administration of the heparin is the subcutaneous route, always recommended. Yes, measles vaccines are administered by which route? Measles vaccine. Can anyone tell? Yes, measles vaccine also administered with the subcutaneous route. Yes, very nice of you all. Okay, but a test dose is given by the intradermal route, not subcutaneous. Okay, all the test doses, whatever it may be, antibiotic test dose, iron test dose, iron sucrose test dose. Okay, whatever the test dose you are giving, that is by the intradermal route. Okay, and Montex test also. Yes, Montex test to in TB patient, we need to screen for the Montex test. So there also we need to administer the purified protein derivatives. Yes, that is also given via intradermal route. Okay. Yes, all test dose and Montex test is always by the intradermal route. Okay. Subcutaneous route, we have to administer the insulin, heparin, and measles vaccine, and most of the drugs which we can't give through the IV and we want fast absorption means we have to give that one by the subcutaneous route. Okay. Yes. So we can't administer this one into the muscle tissue. We can administer into the subcutaneous tissue. So option A I am eliminating here. Yes. Then comes to the option B. Yes. Inject the insulin into the subcutaneous tissue using the 90-degree angle. So, sir, we studied that the subcutaneous injection should be given at around the 45-degree angle. Yes. You people have studied this one. Administration of the any drugs into the subcutaneous tissue means we have to use the 45-degree angle. But here it is given the 90-degree angle. Is it correct? Yes, it is correct. Why? Because for administration of the insulin, we are using one specific syringe, that is what we call as the insulin syringe. Okay, so this insulin syringe, which is having the maximum of the 40 units. Okay, so this is equal to the 1 ml. This is equal to the 1 ml. Very importantly, so all the AIMS hospitals, JIPMER, okay, and all the central institute using this syringe only. There are many syringes in the markets which are labeling of the 1 till 160 units, but the always recommended one is the this maximum 40 units syringe we will recommend. So this is the insulin syringe. After opening this cap, there is very small, okay, very small needle will be there. So this, if we are giving into the 90-degree angle to the skin, this is the skin. Okay, so this is the needle. If you are giving to at the 90-degree only means it will go till the subcutaneous fat. Otherwise, it will won't go till the subcutaneous fat. So insulin will be administered by using the insulin syringe. So this is the insulin syringe. So it should be administered over the 90-degree only. Okay, it should be administered by using the 90-degree. So one another scenario based questions that may comes in your exams for less subcutaneous fat. Okay, any person who is having the very less subcutaneous fat means for those kind of the people we should use the 45-degree. Okay, For those kind of the people, even by giving this syringe, we should use 45 degree. Okay, why? Because very less subcutaneous fat, that time we are 90 degree means the syringe may go till the muscles. Okay, so that is the reason the needle may go till the muscles. So that is the reason for very less subcutaneous fat peoples we are using the 45 degree angle, and almost all the normal peoples and obese peoples we have to use the 90 degree syringe for the administration of the, yes, insulin. Okay, so hope the concept is clear. So inject the insulin into the subcutaneous tissue, this is the correct, and by using the 90 degree angle, so this is also correct. So for better absorption we have to give it in the subcutaneous tissue by 90 degree angle, that is the correct answer. So option C is telling here inject the insulin intravenously for rapid action. But there is one situation in medical system. So almost all of you know that that is the complication of the diabetes, that is the diabetic ketoacidosis. Okay. So for managing this one, or uncontrolled hyperglycemia that is more than 400. So for managing that one, sometimes doctor may advise IV insulin. Okay. IV insulin. Very, very importantly. So IV insulin, there is only one insulin we can give by intravenous route. Which insulin we can give by IV route? Only one insulin we are having that recommended to give the IV route. That is the, yes, very nice of you all. That is the regular insulin. Okay, regular insulin is the only insulin that we can give by the IV route. So the scenario based questions they may create here. You are giving the insulin by IV route means it is going directly inside the blood. So it may shift the potassium directly from the intravascular space to the intracellular space. Yes. So that is the reason the person who is taking insulin, we have to assess for the hypokalemia. Why? Because it shifts the potassium from the intravascular space to the intracellular space, or we can say from the extracellular space to the intracellular space. So it is shifting the potassium means it is decreasing the potassium. So as a complication of the insulin therapy, we can see the, yes, hypokalemia. So if you are giving insulin by IV route means before that you people must and should have the serum electrolyte report. Okay, serum electrolyte which is containing the sodium, potassium, and calcium, everything. So among this, potassium is very much important. So if the patient is having the hypokalemia and if the patient is having the hyperglycemia, means we need to start both together. Okay, we need to insert two IV cannula. Okay, so then start in one IV cannula injection potassium. Okay, so that is the 40 milliequivalent standard dose I am telling bachon, 40 milliequivalent in 400 ml NS for 4 hours, or we can say 100 ml per hour. Remember, potassium never ever give IV bolus. You are pushing the potassium directly IV bolus means the patient will get die. Okay, so this is the dose of the injection potassium by one IV cannula. And in another IV cannula, yes, we need to take the regular insulin. Okay, so along with the regular insulin, we need to dilute and put in the syringe pump, and we will start the infusion slow IV. Okay, so two options we are having here, very importantly. So that is the, while managing the diabetic ketoacidosis, IV insulin is recommended. Only the one insulin that is given by IV route is the regular insulin, and for giving the IV insulin, we need to make sure that the potassium level should be normal. If it is hypokalemic, then we will start both injection KCl plus insulin together. Okay, so if while giving the IV insulin, the blood glucose level which is coming less than 250 means suddenly stop the infusion and inform to the doctor and start the DNS. Okay, so this is the, yes, very much important. That is what, while giving the IV insulin, we need to monitor the blood glucose level every hourly. Okay, how instantly we need to monitor the glucose while giving the IV insulin? Yes, that is the Q1H. Every 1 hourly we need to monitor the, yes, glucose level while administering the IV insulin, that is the regular insulin. Most importantly, consider this one and keep ready the dextrose at the bedside. Why? Because the patient anytime may go into the hypoglycemia. So that is the reason we need to keep the dextrose also ready. Okay, so and treat aggressively in the diabetic ketoacidosis case. Okay, hope the concept is clear for this one. And here is the next question. Okay, yes, sorry, one more option left here, bachcho. So I told here inject insulin intravenously for rapid action. So this is only for managing the diabetic ketoacidosis, not in the usually. Okay, so then comes to the option D, that is the inject the insulin into the fatty tissue near the navel. Navel here means the umbilicus. Okay, for slower absorption they written. No, this is the perfect site and it is for the faster absorption. It is not for the slower absorption. So I am striking the word slower here. Okay, this is the faster. So that is what I am eliminating option D also. I am eliminating option C also, and option A is always eliminated here. So that is the option B goes to the correct answer. It is given at the 90-degree angle subcutaneous fat. Okay, clear. So best site for administering the subcutaneous injection is the, yes, over the abdomen. Okay, so and yes, there should be a gap of the 2.5 centimeter or 1 inch. 1 inch or 2.5 centimeter gap should be there for each every injections. Okay, sorry. So for first and second dose of the injections, consider. So this is the navel. Just a second, please. I will take a new slide. So it is confusing you all. Okay. So consider this is the abdomen and this is the umbilicus or the navel. Okay. First injection you are giving here means for first and second injection there should be at least 1 inch gap. Okay, 1 inch gap, or we can say 2.5 centimeter gap should be there between the first and second pricks. Okay, hope the concept clear. If you are pricking consistently over the one place only means which causes the lipodystrophy. Okay, so there will be a dystrophy of the, yes, the subcutaneous fat will be there. That is the reason we should maintain the, yes, 2.5 centimeter or the 1 inch gap between the two injection sites. Okay, so clear bachcho, and this is the surround the umbilicus is the best site. This is the always best site. It provides the fast injection. Very much important, and it provides the faster absorption. Yes, clear. Yes, so here is the next question in front of you all. So do read the question properly, perfectly, then try to give the best answer for this one. Okay, so which of the following best describes the relationship between the atrial fibrillation and the stroke risk? This is the most important question. Okay, so this is the most important question. Students, the question is like this: a person comes to the emergency department with the atrial fibrillation, and along with the antiarrhythmic drugs, which of the following drugs should be given immediately? Okay, in question only they have written the patient came with the atrial fibrillation, and along with the antiarrhythmic drugs, which drugs you will expect? They asked like which drug we can give next. Okay, so in the options there is digoxin was there, and in the options there is heparin was there. Okay, so many of the students they have clicked the answer as a digoxin, but it is wrong answer, students. So immediately after identifying the atrial fibrillation, so which increases the risk of the stroke by activating the clot, so we used to choose for the heparin as the best option there. Okay, so many of you people have done the mistake, so don't repeat that mistakes again. Okay, so the question is like this here, the simple and important, most important concept you people have to understand, then the management also I will tell, so it will be easier for you all to understand and give the best shot in the exams. Okay, so the question is which of the following best describes the relationship between the atrial fibrillation and stroke risk? Yes, option A is telling that the atrial fibrillation significantly reduces the risk of the ischemic stroke due to atrial fibrillation not reduces, it increases the risk of the stroke. Okay, so that is the reason. So option A I am eliminating here. Then comes to the option B, atrial fibrillation increases the risk of the ischemic stroke due to the formation of the blood clot in the atria. This is the correct and perfect answer. Okay, so in the atrial fibrillation, the left atrium is shaking, means the clot which is there over the atria will get activate. So the clot is activating means when the left atrium contracts, it will go blood to the left ventricle, when the left ventricle contracts, it will go blood to the carotid artery and all part of the body. So if the by mistakenly if the clot entered into the carotid artery, means it will go to the cerebral artery, okay, and which blocks the circle of Willis, and there is a chance of the stroke will be there. Okay, so always remember the atrial fibrillation increases risk of the ischemic stroke by formation of the blood clot in the atria is the most important thing you people have to understand. And immediately after identification of the atrial fibrillation, we need to start heparin. We need to start heparin as soon as possible. Okay, so as soon as possible, we need to start the heparin immediately identifying the atrial fibrillation. Why? Because which increases the risk of the clot formation, and the clot will block the or brain vessels, so it may leads to the yes the stroke here. Then yes, option C and D they have given. So this is the not correct answer here. Okay, so clear, bachcho? Yes. So here is the one short advertisement for all that is related to the Sure Selection Test Series. So Sure Selection Test Series, which is prepared by the expert AIMS nursing officer in the Master Nursing Classes application. The test will get live daily in the morning 6 a.m. and it will close at 11 p.m. in the night. Anytime between 6 a.m. to 11 p.m. you can practice that one. Okay, you people can give the exams same like your exam pattern. Okay, so then after at the exactly at the 12 a.m. midnight, you people will get the top 20 rank holders list in our official Telegram group. Okay, so this particular source selection test is completely focused over the RB nursing superintendent, NORCET8 and CRE ASSC exams. Okay, so this yes single solution for all three exams where most important questions, repeatedly asked questions, concept with the rationality and so if you people want, so do contact this number. The sir will guide everything how to practice, what to practice, and how to buy the test series. Everything the sir will explain you. That is the number is 8296554687. Okay, so this is our relationship manager number. So you can call anytime. So sir will guide you. Yes, accordingly. Yes. So here is the next question. Bacho, do ask the question, read the question carefully, properly, perfectly, then give the best answer for this question. Okay. So which of the following statement is true regarding normal lung sounds? Okay, so regarding the normal lung sounds, which of the following statement is true? Option A is telling that the normal lung sounds should be harsh and loud in all areas of the lungs. No, bacho. So we are having the three lung sounds normally we will get. Just a second, please. There is the bronchial lung sounds, there is the bronchovesicular lung sounds, and vesicular lung sounds. Yes. So among these three, vesicular is the low pitch, bronchovesicular is the medium pitch, and bronchial is the high pitch. In the option A, they have given normal lung sound should be harsh, means all the lung sounds should be harsh. They have given no. So we are having the normal lung sounds as a low pitch, medium pitch, and high pitch. Always so I'm getting the option A here. Yes. So then comes to the vesicular breath sound are heard more prominently during the expiration. No, bacho. Vesicular lung sounds we will hear over the entire lung field. Okay. So this is the entire lung field. So by keeping the stethoscope over here, so auscultator sound we are hearing is the vesicular sound. Yes. The questions will come. So to hear the vesicular lung sound, where we have to keep the yes the stethoscope, that is the over the lung fields we have to keep the stethoscope. And as the vesicular lung sound, the inspiration is more than the expiration. Okay, so 3:1 ratio will be there here. Okay, so inspiration is to expiration we are calculating in the vesicular area, means yes means the entire lung area. During the inspiration, yes, the prolonged sound will come, and during the expiration, little sound will come. So the inspiration is to expiration ratio here, that is the 3:1 in the vesicular lung area. Okay, so in the option they have given, it is more prominently during the expiration. No, the sound is more prominent during the inspiration. During the inspiration, the sound is more prominent. So option B also, right? Yes. Then come to the third option, that is the bronchial breath sound, or normally only over the trachea. Yes. Here, look at the image. So, this is our beautiful trachea. By keeping the stethoscope over the trachea, we can hear the bronchial sound. Okay. So, this bronchial sound is the high pitch. The bronchial sound is the high pitch sound. And yes, the inspiration is to expiration ratio for the bronchial sound is expiration will be more here as compared to the inspiration. That is the 2 is to 1 ratio. Means expiration will be here prolonged, then little bit of the inspiration will be there. So expiration is the 2 is to 1 ratio, bacho. Okay. So this is the expiration is to inspiration, and here is the inspiration is to expiration. Clear? And when we come for the bronchovesicular sound, that is the medium pitch sound, it will come. So this bronchovesicular sound or the medium pitch sound, so it is 1 is to 1, means the equally the sound will become equal here. Okay. So inspiration is expiration. Clear, bachcho? And yes, here is the complete description of the all lung sounds. The vesicular breath sound, very importantly, that is a soft low pitch sound. Okay, so it is longer during the inspiration and short during the expiration. And location of the vesicular breath sound is the peripheral entire lungs area. Okay, so on the lung area, bacho, we will get the vesicular breath sound as a normal. If in case you are keeping the stethoscope over the lung fields and you are not getting any kind of the sound, or you are getting the diminished sound, that indicates, yes, that indicates the pneumothorax, means the accumulation of the air in your pleural space which compressed your lungs, and lung is not expanding and the air is not coming in the lungs. So that is the diminished breath sound will be seen in the pneumothorax, hemothorax, and yes, the chylothorax. Yes, if in case the fluid are accumulated in the in the alveolar space, okay, that condition we call this one as the pulmonary edema. In the pulmonary edema, the fluid will accumulate in the alveolar space and in between the alveoli. You are assessing the lung sounds during the pulmonary edema, means you will get the crackles. Okay, so the crackle is not normal. The crackles we are getting in the pulmonary edema, and diminished breath sound we are getting during the, yes, pneumothorax, hemothorax, and chylothorax. Yes, clear? And over the lung fields, normally vesicular breath sound should be come. If in case the sound which is come after keeping the stethoscope or the trachea is the bronchial sound. So this kind of the sound we are getting over the lung, peripheral lung field, means that is the indicating of the pneumonia. Okay, the classically they will ask which kind of the sound we can hear during the pneumonia. One is they will give the crackles. Okay, that is also correct answer. Another one is the bronchial like sound over the lung fields. Bronchial sound should be come over the trachea, that is the normal. Okay, so bronchial sound which is coming over the lung fields means that indicating the pneumonia. Remember, okay. So here's the complete description of the vesicular breath sound. Then come to the bronchovesicular breath sound. Okay, so look at the image, bacho. Here, bronchovesicular breath sound will be heard here over the main branch of the our trachea and bronchi. Okay, so that is towards the carina. Okay, this is the our bronchi. Okay, so over the primary bronchi, if we are keeping the stethoscope, means we can hear the bronchovesicular breath sound. Okay, so description is the very clear. That is the, it is a moderate pitch sound. Okay, then inspiration and expiration are equal duration. Clear? So next to the location, as I told, on the major bronchi. Yes, clear, bacho? Very nice of you all. If sound issue is there, our technical team will resolve it in second. So kindly cooperate, please. Yes. So here is the next one. That is the bronchial breath sound. Bronchial breath sound, I heard it is be to hear the bronchial breath sound, we need to keep the stethoscope over the trachea. Yes. So if we are keeping the bronchial breath sound over the trachea, means we can hear the shallow, high pitch sound. I told the vesicular sound is low pitch, the bronchial sound is high pitch, and bronchovesicular sound is medium pitch. Okay, the inspiration is to expiration ratio for the vesicular is the 3:1. The inspiration is to expiration ratio of the bronchovesicular is the equal 1:1, and over the bronchial sound, so expiration will be heard more than the inspiration. That is the 2:1. Expiration is to inspiration ratio over the or trachea or the bronchial sound is the 2:1. Clear, bacho? Yes. So this is the in-depth description over the all the normal lung sounds. Okay. So option D here it is telling the crackles are typically considered normal in the healthy individuals. No, the crackles indicates whether the pneumonia or pulmonary edema. Clear? Yes. So option D also I am eliminating here, and option C is the correct answer. Yes, option C goes to the correct answer. That is the bronchial breath sound are normally heard only normally over the trachea. Okay. Yes, the bronchial breath sound normally heard only over the trachea. If by mistakenly the bronchial sound which is coming over the peripheral lung fields, here we are getting the bronchial sound means that indicating the pneumonia and congested lungs. Clear, bachcho? So hope the concept what I have explained here in this today's class is clear, I think. And here is the one more important questions for you all. Okay, so which of the following is a hallmark sign of the severe preeclampsia? Try to give the correct answer for this question. Yes, which of the following is a hallmark sign for severe preeclampsia? Option A is telling that the blood pressure greater than or equal to the 140 and 90 by 140 by 90 mm of Hg. Then option B is the proteinuria less than the 0.3 gram per day. Option C goes to the blood pressure greater than the or equal to the 160 by 110 mm of Hg. Then option D goes to the edema of the lower extremities. So the question is hallmark sign of the severe preeclampsia we need to tell here. Yes, that is the not only just preeclampsia, it is the severe preeclampsia. Bacho, so let me explain the important things on the pregnancy induced hypertension so you people will get clear concept over this one. Okay, so a female comes to OPD with the blood pressure of the more than 140 by 90 mm of Hg. Okay, so blood pressure of the female is more than 140 by 90 mm of Hg. Okay, so before the pregnancy you will ask whether this high BP you are having before pregnancy or now only. Will ask, she will tell. So before pregnancy also I am hypertensive, she will tell. So the BP higher before pregnancy also and now also in pregnancy also. Okay, before pregnancy also high BP was there and during now pregnancy also high BP was there. This is what we call the chronic hypertension in pregnancy. Means the hypertensive woman she got pregnant now, so that is what we call as the chronic hypertension in pregnancy. Okay, so if in case the BP more than 140 by 90 mm of Hg after 20 week of the pregnancy, after 20 week she is getting, yes, pregnant, sorry, after 20 week she is getting high blood pressure. So this is what we call as the pregnancy induced hypertension, means the hypertension which is came here because of the some placenta problem during the pregnancy. Okay, so pregnancy induced hypertension is the problem of the placenta. Okay, remember the question will come here, after how many weeks we can diagnose the PIH or the pregnancy induced hypertension? After 20 week we can diagnose the pregnancy induced hypertension. They will ask the definition criteria also. The BP will be more than 140 by 90 mm per G. Okay, so after 4-hour gap in 2 occasions. First time we will assess the BP. Okay, so we will give the 4-hour gap. Then again we will assess the BP. Okay, so after 2 successive readings, which is giving more than 190 mm per G, after 20 week of the gestation, we call this one as in the pregnancy induced hypertension. Clear? So in the pregnancy induced hypertension, again we have divided into the gestational hypertension and preeclampsia. Pregnancy induced hypertension is there, means the BP more than 140 by 90, but no proteinuria. Okay, but no proteinuria. BP is higher but no proteinuria, so that is what we call as the gestational hypertension. So high BP plus proteinuria, we call this one as in the high BP after 20 weeks plus proteinuria, we call this one as in the preeclampsia. What we call this one as in the preeclampsia. Okay, so in the preeclampsia there are two types of the preeclampsia: mild preeclampsia, then severe preeclampsia. Yes, So in the mild preeclampsia, the BP may go more than 140/90, but always it is less than 160. Mild preeclampsia BP will not go more than 160/100. Sorry, the BP may go more than 140/90, but not more than 160/110. Yes, but in the severe preeclampsia, the classically the hallmark sign of the severe preeclampsia is BP. It will go more than 160 divided by the 110 of Hg. So this indicating the severe preeclampsia. Okay, so proteinuria will be there in both mild preeclampsia and severe preeclampsia. But in the mild preeclampsia, along with the high blood pressure and proteinuria, so there will be a no sign of end organ damage. Okay, no sign of end organ damage. But during the severe preeclampsia, the BP is more than 160/110. Proteinuria will be also there. Plus, in the severe preeclampsia, sign of end organ damage will be there. Okay, sign of end organ damage will get in the severe preeclampsia. So, untreated severe preeclampsia, okay, severe preeclampsia plus seizure, we will call which kind of the seizure? That is the generalized tonic clonic seizure. We call this one as in the eclampsia. What we call this one as in the eclampsia. Okay. So, the criteria they can ask in the exams, okay, severe preeclampsia plus seizure, that is the generalized tonic clonic seizure, we call this one as in the eclampsia. So that is very important. And here in the option they have given the blood pressure is greater than the 140/90 mmHg. This is the mild preeclampsia. Okay, so we can say pregnancy induced hypertension, this one. Okay, with more than 140/90. So we call this in the, yes, we call this one as in the plus proteinuria. Please wait. Plus proteinuria. Yes. So that is what we call as in the preeclampsia mild. Okay. So if BP which is more than 160/110, so that is classically indicating the severe preeclampsia. Here in the severe preeclampsia, blood pressure will be greater than the, yes, or more than or equal to the 160/110 plus proteinuria plus sign of the end organ damage will be there. But edema and proteinuria will be there, both there in the mild and both severe preeclampsia. But BP will be not more than 160/110 in the mild preeclampsia. It is always below the 160/110 in the mild preeclampsia. Okay, so if it is crossing 160/110 with the end organ damage plus proteinuria, we call that one as in the severe preeclampsia. Severe preeclampsia plus generalized tonic clonic seizure, if pregnant woman is pursuing, means that is what we call as in the eclampsia. So this is all concepts of the day. Okay, what we have discussed today is the very important thing. Okay, so that is all the hallmark sign of the severe preeclampsia, that is BP more than 160/110. Okay, with proteinuria plus end of the sign of the end organ damage and normal lung sounds. Okay, three lung sounds: vesicular, bronchial and bronchovesicular, all we have discussed in detail. Okay, so then scenario based questions. Okay, so we have seen small advertisement on our test series, that is, and if you want to choose our test series, so do please contact over this number, so our relationship manager will help you. Okay, so and we have discussed the relationship between the atrial fibrillation and the stroke risk. Okay, always in the case of the atrial fibrillation, okay, consider there is highest chance of the stroke will be there, so give the heparin as a priority drug here. And so we have discussed how to administer the insulin. Okay, so what is the degree in the less subcutaneous fat, and what is the angle of the insulin in the is normal person or the fatty person, we have discussed. Okay, so and we have discussed over the, yes, very importantly, supine hypotension syndrome and many questions along with this one we have discussed. Okay, so this is all about the today's class, and in the tomorrow's class again we will discuss the most important thing. Okay, so that may helps you for your upcoming exams. So stay connected with the master nursing classes for clearing your concept and getting the good rank in the exams. Okay, so we'll wind up the today's class here, and I'm waiting for you all in the tomorrow's class. If any technical issue resolved, if not resolved, so I will make sure in the next class it won't be repeated, because some new instrument we have added in our studio, so that is making some inconvenience. Okay, so we'll make sure and we'll fix the issue. Okay, don't worry about that one. We'll meet in the tomorrow's class. तब तक के लिए जय हिंद जय भारत, धन्यवाद.